Good afternoon and welcome to United TV. My name is Kamal Erkan. Today in our 2 p.m. sessions with our clinical presentations, Dr. Sachin Vaid from Christiana Institute of Advanced Surgery is going to be with us. And our topic is the colorectal cancer awareness. And it will be hopefully providing a lot of useful information for our patients and for those others who may have similar issues in colorectal. Dr. Vaid is with us, and also Donna Dunkel, our Clinical Integration Director, is with us. So we'll be starting the presentation now.
Thanks, Kamal, for the introduction.
Thank you.
Hi, Donna. So today we're going to be talking about colorectal cancer as we stand in 2024. In the past, I've given this presentation, I think, a few years ago, but of course now we have more updated data, and I'm happy to share that with you. And we will go ahead with the presentation. All right, Donna, can we move on to the next slide, please? So, as you guys probably know, colorectal cancer is one of the most common it is the most common malignancy of the GI tract, and it is the third most common cancer worldwide and accounts for approximately 10% of all cancer cases and is the second leading cause of cancer-related deaths. So, just to summarize, it's the most common cancer of the GI tract, and it is the second leading cause of cancer deaths, honestly speaking. So it is a very important problem. It is a high volume of cancer cases we see, and it can be prevented, and it's one of the leading killers from cancer causes. Approximately 4.4% of men and 4.1% of women will be diagnosed with colorectal cancer in their lifetime. The good news is that from 2001 to 2019, which is very new data, the incidence rates have dropped by about 1% each year. But this downward trend is mostly seen in older adults, meaning above 65 years of age. In people who are younger than 55, and this is alarming, that the rates have actually been increasing by 1 to 2% every year since the mid-1990s. And that is very concerning and alarming. And you'll know why when I show you the next few slides. Next, please. So in this slide, what we are saying is we are looking at all the, basically it's from 2000 to 2021 is the database where we've extracted this from the SEER database. And we are looking at both the incidence and the mortality. If you can see, the blue line is the incidence, and this line was beautifully coming down. As you can see, it was a very good incline, very good ramp, but suddenly there was a bump around 2011. And now that downward drop is not as robust as it was, and it is trying to flatten out, meaning that the incidence rate, the rate in which it was dropping has slowed down. And the mortality also is going down, but again, it is not going down in that robust fashion as it was before 2010. Let's go on to the next slide, please. So in this one, we are looking at people less than 50 years of age. So we are not looking at all comers. The first slide was all comer. This is only people less than 50 years of age. And in this, you can see the blue line is the incidence. And the incidence has sharply risen up after 2010. As you can see that the blue line is inclining acutely upwards. And the green line, which was supposed to go down, is basically flattening, or if anything, trying to go up. And the reason for that, I think, is because people less than 50 years of age, we typically are not even screening them because, they in the past, they didn't even fall in the criteria of getting colonoscopy because screening age was 50 years of age. Only recently, we've kind of dropped it to 45. But even at 45, I mean, most of the people who are getting these cancers and contributing to the high mortality are probably people in their 30s and 40s, honestly speaking, who we're not screening and who have advanced disease. In this one, we looked at 50 to 64. Even in this, both the blue and the green line is going in the wrong direction. Blue line was going down, the incline was going down, but now it's going up after 2010. So people less than 65, something has happened to the general population. And we can see both the incidence is going up. And because the incidence is going up, and we are not able to screen these people at an early stage, I think the mortality also is following that trend and is going up. And this is very, very alarming. Let's go on to the next one, please. So what causes colon cancer? Okay, so it is multifactorial, meaning there are various factors which are involved. The first and the foremost is the genes you are born with. Okay, what kind of genes you have, what chromosomes, uh, how are the chromosomes from those genes being affected? What mutations do your DNA get, which leads for you to get a colon cancer? The second one, which is actually preventable, is environmental factors, meaning diet high in red meat, low in fiber, sedentary lifestyle, alcohol consumption, smoking, obesity. This is preventable, guys. This we can prevent because if we change our diet to a high fiber diet, low in red meat, meaning not taking red meat every day, but maybe once a week or once a month, and just making sure a healthy, fibrous diet every day, and we start to walk around doing some exercise and kind of curtail our alcohol and smoking, I think we can make a dent there because these are the factors which are under our control, unlike genetics. I mean, that's just bad luck. I mean, you were born with it. So what can you do about that? Or any mutation which happened. The last one is inflammation, meaning ulcerative colitis and Crohn's disease. Again, that's not something you can control. That's a disease you just get. And that also puts you at a higher risk for getting colon rectal cancer. You can check if you can control your smoking and your drinking, and of course take a high fiber diet, low in red meat. When I say low in red meat, I don't mean no red meat. I just mean low red meat, meaning don't take it every day. Just make sure that you're incorporating your fiber every day. Next, please. So typically, what's the presentation? The problem is that typically it is asymptomatic. By the time there are symptoms, we are already late in the game, meaning the cancer has gotten bigger. It's already an advanced stage cancer. It's not an early stage cancer anymore. Um, Commonly, when someone has anemia, meaning a low hemoglobin count, or if they are having rectal bleeding, or we are doing a routine colonoscopy, that's when we diagnose these colon cancers. And the common presenting symptoms, if there are symptoms, meaning it's advanced already, is you'll have abdominal pain, you may have altered bowel habits, rectal bleeding, weight loss, which is the last one. Weight loss means that if things have advanced a lot by that time. Next slide, please. Definitely. I mean, we are all talking about doom and gloom so far. It's one of the commonest cancers. It's one of the biggest killing cancer. It kills a lot of people. It is deadly for sure, but it's totally preventable and curable. So that's the most common. That's the most important point I want people to understand. That this is, yes, it is deadly. Yes, it is common, but yes, it can be prevented, and we can totally cure it. You cure it, and you're done, and the cancer may not even come back. So how do we prevent it and how do we cure it? The key to cure is to kind of diagnose it at an early stage or even at a pre-cancer stage when it is not even a cancer. So that's the key to actually prevent curing this cancer. So screening is the most common or the most effective way in which we can prevent this cancer and actually cure this cancer. And the most commonly recommended screening tool is colonoscopy. The average risk for any average risk person now, it is not 50, it's 45 years of age, and we repeat it every 5 to 10 years depending on what they had. If you do have a family history, meaning your first degree relative having cancer or more than one second degree relative having cancer, you got to do more frequent exams. You got to start early, about 10 years before the index case, or around 35 to 40 years of age. And of course, if you have these genetic syndromes like FAP, HNPCC, then you got to start early. Or if you have ulcerative colitis, Crohn's, again, start early, and we got to repeat it every 1 to 2 years. All right, next one, please. So what are the various options we have? So whenever, I mean, we see a lot of advertisements on television that, okay, get screened, these are the options and this. So the first and the foremost, let's just keep it simple, is a stool-based test. Basically, we are trying to test someone's stool. So there are various tests on that. Either we are checking someone's stool for some immunochemical testing, or we are doing a blood test in the stool, just looking for if there is any microscopic blood, or we are looking for a DNA change, which abnormal cells or abnormal polyps or cancers shed abnormal DNAs in your stool, and that can be tested. And that is a commonly known test known as a Cologuard test, you might have heard of. in the advertisements. The next one, or the best one, I would say, is basically a visual exam of someone's colon and rectum. How do we do that? We do it by colonoscopy, and we repeat every 10 years if it is normal. If someone cannot get a colonoscopy because they cannot be put under anesthesia or for some anatomical reasons, we can also do a CAT scan colography, which is a virtual colonoscopy. The problem with that is that it would detect a polyp, it would detect a mass, it may detect something, but then it cannot remove it. So the reason why colonoscopy is the best test, in my opinion, and actually in all of the, if you look at the colorectal data, that's what they, and even the gastroenterologist, the recommendation that the best screening exam is a colonoscopy is that you can both diagnose and do therapeusis, meaning you can actually remove that polyp, which is in a precancer phase, or take biopsies of a cancer if it has already formed. Of course, if a person chooses to be screened by a test which is not colonoscopy, any abnormal test has to be followed by a colonoscopy. So I would highly recommend that if you are a good candidate, if you're a healthy candidate, you should get yourself screened by a colonoscopy. All right, next one, please. Another question that I get very often asked is, what is the difference between screening with a Cologuard test or a stool DNA test and a colonoscopy? So let's make it very clear that what Cologuard test is. Basically, we are checking for abnormal DNA in your stool, which basically are being shed off by cancer or precancerous polyps, which are advanced. So a stool DNA test is a screening test, but it is not preventive because we are already finding cancer cells, because the cancer cells have already developed. That's what your body is shedding. So we kind of missed the boat there, that we could have actually caught these polyps which were less advanced while they were not shedding these abnormal DNA tests, and could have killed or removed them. But now we are at a stage that we have either advanced polyps, or we are at a stage that we already have a cancer. So it is not preventive. It is definitely good for screening, but it is not preventing the progression, so to speak, or us to even diagnose a early stage polyp, which has not even turned into advanced polyp. On the other hand, colonoscopy can be used for both screening and prevention, because it can find colon cancer in a person who has no symptom, which is known as screening, and can also remove suspicious looking polyps before they develop into advanced polyps or advanced cancer. Hence, it is both preventive and used for screening purposes. You can go on to the next one, please. Okay, so how do these cancers present? Like, what is the distribution? So when we talk about cancer, we talk about stages. Okay, we talk about stages, meaning is it a localized cancer? Has it gone into the lymph nodes, or has it spread to the distant parts of our body? For colorectal cancer, typically the distant spread is either in the liver or lung. Regional in this graph means that it basically has gone already into the lymph nodes. And localized means that it is still in the organ of origin, meaning it is still inside your large intestine, be it colon or be it rectum. So if it is localized, which you can see it's about 33% of the population between 2014 to 2020. If it is localized, which is 33%, it's about one third of the population. It's a very good prognosis. Prognosis means outcome is actually very, very good. As you can see on the bar diagram on the right hand side, that when it is localized, your 5-year survival is close to 90%, which is a great survival, meaning most of the people are cured of this disease. And the good part, and the other good part is, if you're localized, for the most part, you're not even going to need chemotherapy. All you need is surgery. Surgery has removed the cancer, it's gone out of your body, and life is good. The other one is regional spread, which is about 40%, as you can see on the pie chart here in the green. And even with that, if you see on the right hand side that the survival is still very high, 5-year survival still is upwards of 72%, which is great. And the reason why we are able to achieve that, let me tell you, in the past, this stage, which is regional stage, which is also known as stage 3 cancer, the survival used to be dismal. It used to be about 40 to 50%, 5-year survival. But now with the advancement in chemotherapy and with the tailoring of the chemotherapy, depending on the kind of cancer you have, we actually check the DNA markers on the tumor which we remove, and we tailor the chemotherapy accordingly. Not everyone gets the same chemotherapy. People get chemotherapy based on the kind of DNA markers they have. And it's because of that that we are able to achieve a 5-year survival of upwards of 72%, even in a regional disease when things have spread to the lymph nodes. The next one is basically distant disease, which is in gray on the pie chart, about 22%. Still a large number, I would say, about one-fourth, just less than one-fourth, just less than a quarter of the population. Even in that, if you see, the 5-year survival, of course, has drastically dropped from 90% in the localized to 16%. But again, I did the same presentation a few years ago, and here the 5-year survival was 5 to 10%. So again, we made an improvement even in people who have metastatic disease in that fact that they survive longer. Although, of course, the numbers are less compared to the localized. So the key here is to find early cancer or no cancer, prevent a polyp from turning into cancer. But if anything, you want to find a early stage 1, stage 2 cancer, so you can actually achieve a more than 90% 5-year survival rate, and you can actually also avoid getting any chemotherapy. Next, please. So what's the treatment? I already alluded to it as you were talking about the stages and stuff. The surgery is the commonest way you actually treat all colon cancers, unless you have a metastatic disease. And surgery, it can be completely curative in early stage disease, meaning you don't even need any chemotherapy or immunotherapy, anything like that. Surgery can be done with the help of the laparoscope, robot, and open. I would tell you, in my practice, more than 95% of these cases are being done in a minimally invasive fashion, and we commonly deploy a robot to do the surgery. And when I say deploy a robot, it's not like the robot is running the show and I'm having coffee in the lounge. No. I'm actually doing the case, and the robot is being controlled by me. But the thing is that it's a very smooth operation. It's a technically very good operation when you are able to kind of use the robot, and the results are great because the incisions you make are very, very small. People typically get out of the hospital, I would say, in 1 to 3 days. They don't even need to stay in the hospital. In the past, they would be in the hospital for 7 days, 10 days, and all that. But commonly now, with the robot and the laparoscope, we are able to get them out in 1 to 3 days, which is great in my opinion. And as I said, in early stage, it can be curative. Of course, if it's advanced, then you need chemotherapy, immunotherapy. Immunotherapy is a new one. It wasn't there up until a few years ago, but the latest research, again, based on the DNA and all that stuff from the individual tumors, we can tailor, okay, this guy should get this immunotherapy or, this particular kind of chemotherapy. And for rectal cancer, basically, you use radiation also in addition to surgery and chemotherapy. The sequencing could differ in rectal cancer. Sometimes in rectal cancer, people get upfront radiation and chemo first before they actually undergo surgery, or vice versa, depending on what the tumor is. And for all rectal cancers, we discuss them in our committee, which is called the Rectal Cancer Multidisciplinary Committee. And it's at the cancer center over there. I'm the surgeon, I'm the lead surgeon there. And then we have the radiation oncologist, and we have the chemotherapy doctor who's the oncologist. And we all sit down together and make a plan based on what the patient has, what's the best way to kind of proceed with that particular kind of tumor. So it's very tailored to what you have rather than one size fit all approach, so to speak. Next, please. All right, I think that's what I had for you guys.
All right, Dr. Vaid, thank you for the presentation. So this is one of the most important maybe disease out there from the level of number of people who are losing their lives. Although if it can be early detected and diagnosed, it can be a life-saving experience, versus if we wait, it's going to be not so pleasant for those. Something that is as simple as just doing a screening I know now that went from age 50 to age 45, the recommendation. Someone who's at 50, I got my colonoscopy 2 years ago. Especially, I guess, men makes a little bit too much out of the overall experience, but look, this is life, and then you guys are trained medical professionals. So for us, from the patient standpoint, we shouldn't really have those types of feelings, because when it's delayed, it can be deadly. So
Absolutely.
it's so simple. If you be delayed, it can be deadly. So that's why we try so hard to do the screenings in a timely manner, and that's a game changer if you are able to you know, diagnose these early on. So many patients probably are going through that, thinking of like, oh, like I don't want to be in the doctor's office for this, but you know what? Just this is life. So
Kamal, as I showed you in my slides, I mean, in the last few slides which I showed, like if you diagnose it at an early stage, localized disease, the survival is beautiful. I mean, you're talking about more than 90% 5-year survival, as opposed to when it spreads, it just falls down to 15 to 16%. So it's a big difference. And I think we can totally make a dent there. I mean, if we screen and we identify people at an early stage, or even in a pre-cancer stage where we can actually take the polyp and prevent it from turning into cancer, I think that's very good. I mean, that would make a major difference.
And I think one of the things that you mentioned also, Dr. Vaid, was people not having symptoms. And I think that's one of the things I see as a nurse, where I feel like patients are like, oh, I feel fine. Oh, I'm good. But they don't realize that we need to catch it. And the whole purpose of screening is that we catch it either at the very beginning or very early on, so that we don't want them to become symptomatic. So I think that's one of the things we just have to make sure that everyone understands, is the importance of screening versus treatment right after they find out they have it. So I'm not sure if you wanted to elaborate on that at all, but something we try to get our patients to see.
You hit the nail on the head. Screening is no symptoms. You don't want to have symptoms. You have symptoms, we already have a problem. We have a problem either with an advanced cancer or an incurable cancer. So we don't want to deal with that problem. We want to deal with polyps, which is not even cancer. We want to deal with pre-cancer polyps, so that we just do colonoscopy, we remove them, and life is all good. Or if anything at all, you want to deal with early stage cancer, again, it's not going to be symptomatic. So very important point. You actually hit the nail on the head there. So screening is absolutely paramount.
So, again, just not having symptoms versus someone like me who had symptoms and still shying away from going to the doctors, because we are probably scared other than being uncomfortable. What I would tell for our patients, people out there who are going through similar issues, this is something that everyone may be going through, and let's not be too shy about this, and then go to the doctors before we really need them. So screening saves lives, and that's that simple. And Dr. Vaid, Donna, thank you so much for joining us today. We'll be back with our Bariatric Friday event at 3 p.m. So that will be our third event today. So we'll see you guys soon.
All right. Thank you, guys.
Thank you.